appreciate y'all coming today. We 1 minute. All right. How many people here have worked with a client who has a new mobility impairment and needs a wheelchair, and they are, a power chair or a manual chair would be appropriate, and they're having a hard time deciding? I know that's something we deal with a lot at our facility. So we're here to tell our story about our ongoing quest to make a person's first wheelchair a success, especially these guys that don't really fit into a clear category. Our hope is that you'll leave this presentation with our new tool and you'll find it helpful. And I do want to give a shout out to Tori Falgren. She's a PT in the Shepherd Center Seating Clinic with me, and she was instrumental in making this happen. It's been a long road. So I'm Mandy. I'm an OT in the seating clinic. I'm honored to be presenting with Ryan. He's a PT on the floor, on the SCI floors at Shepherd Center, and Dr. Spriegel, who is Director of Assistive Technology and Research and Innovation at Shepherd, and primarily a professor at Georgia Tech. So very cool that they're presenting with me. So we're going to go over kind of why we developed it. I don't think there's going to be anything earth-shattering there. We're going to talk about how it developed into what it is. We're going to talk about kind of what it contains and why, how we are managing usability of it, clinician feedback that we got on it when we did a little study with it, what we learned from collecting data, and kind of how we changed it based on what we learned. And we're kind of telling the story just to give you guys some confidence in it. At the end of the day, Tori and I are just a couple of clinicians who want to make the world a better place. But we have put quite a bit into it. So we're also going to go over how to access it. It's open access, and how to use it most effectively. And Ryan's going to go over some case studies that he's put together of people that he's done the fit with. So it's the functional, yes, oh my goodness, that's my nerves. It's the functional impact tool for mobility devices, and I'll be referring to it as the fit. That's why Ryan's up here with me. Okay, so at the seating clinic at Shepherd, we see inpatients who have a new neurodiagnosis, usually spinal cord injury, brain injury. We also see outpatients with a mobility impairment because of any diagnosis that necessitates a wheeled mobility device. This tool that we've developed for inpatients, partially because they're very accessible to us. We can go back and follow up with them, and they're there for a little while. But also because these are the ones frequently that come in not knowing which kind of chair to get. A lot of our outpatients come in, they're already using a chair. They've had a mobility impairment that's been coming on for a while. So all of the data that we're talking about was with our inpatients. So we put the fit together because most of the people, the inpatients that come in, they've seen a wheelchair, but they know pretty much nothing about them. Across the board, I get a handful of people that say, yeah, I learned how to do wheelies in my grandma's chair, and that's about the extent of it. But lack of knowledge about the equipment is just the tip of the iceberg. They also are still learning about this new diagnosis that they have, and they're learning about how this is going to impact them functionally and where they are right now and where they're going to be in 6 months. They maybe haven't even thought about that. And they don't have any idea how the different equipment can help or hinder them because they don't even know what the different equipment is. On top of that, they all have treatment team variability, even within our own clinic, our own center. The physicians, the clinicians, the ATPs have different experiences. We all have our own biases. We have different methods of educating our clients. We have different approaches to the decision-making. There's kind of a continuum between kind of paternalistic and really client-centered, and we all fall in different places on that continuum. And we all have different resources. Even within our own facility, our off-campus outpatient clinics don't have the access to all the equipment that we do inpatient. So all of this variability just kind of made it really appealing to kind of standardize the way that we talk about a first wheeled mobility device. We do want to acknowledge the fact we're very aware that we've got gobs of equipment to trial, and most people don't, and we totally get that. We're very, very fortunate. So we'll kind of come back to that a little bit later. So still on the reasons we're doing the fit. For inpatients, time's kind of against us. They've got their funding sources trying to kick them out. They've got a jillion goals that they're trying to meet. Family training, learning about how their body's working now. They really need something before they discharge so that they can continue to work on the skills that they've been focused on in therapy. And really, it's optimal if the treatment team is involved in the script while they're in center. I'm always of the opinion that you need something for the way you're functioning today. It may not be how you're functioning in 6 months. We'll deal with it then, but we don't want you to lay in bed until that 6-month period comes. And then y'all know equipment's expensive. Funding sources are very limiting on what they'll provide and how often they'll provide it. So you get something you don't love, it's kind of not great for a while. And personal finances are usually challenged by the situation that brought them to be an inpatient in the first place. They're not working, who's taking care of the kids, who's paying the bills, all these things. And then there's variable satisfaction with the equipment and adoption of the equipment. As we stand, so I'll see somebody in when they've had their new injury, and then they come back in 2 years for repairs, and they come back in 5 years for a new chair, and they come back in, however many years because they might be having a skin issue or whatever. So we see them a long time, and we definitely see this variability in satisfaction and adoption. And overall, most people are really happy with the equipment that they get. But some encounter problems, and all of us are in this business because we want to help people and get people functional, and it's heartbreaking whenever it's not working out. And of course, it's really hard to change equipment once it's been provided. I've got a couple examples of this. I had one young lady, I think she was like 17. She had a low quadriplegia injury. So she had some function in her hands, most of the function in her arms. Her treatment team was concerned about her getting around on her college campus and really recommended that she go through insurance to get a power wheelchair, which she did. And while she was in center, somebody donated a beautiful custom manual chair that just happened to fit her. We were able to adjust it to get it to fit her. Beautiful. So she had both of these options. Well, she came back 2 or 3 years later, and she uses the power chair occasionally when she's having a bad day. She likes it. She doesn't want to get rid of it. But her manual chair needs a lot of repairs now, and she can't afford the repairs. What do we do? I mean, it's a tough situation because insurance will only pay for repairs on the chair that they provided. So that's one example. Another example, I have a client from a long time ago. He had a higher level of quadriplegia, and so no hand function, limited arm function, and just really wanted that manual chair with power assist wheels. So I'm not sure how it got funded because I feel like we have a hard time getting that as an initial setup. But it did get funded, and a couple of years later, he comes back. He's got a skin sore because he wasn't able to do his weight shifts. His shoulders are blown. He wants a power chair, and it's not a slam dunk at that point. Like, we can talk about the change of condition, but technically insurance already provided a power chair. So these are all the things that I know all you guys are familiar with too. So all the reasons. So our goals for the FIT were to provide more systematic ways to educate clients and help them explore their options, and think about the impact the different devices will have on their function. Also to identify gaps in their understanding of what we've already gone over. I mean, we all know a client is trained on something, has learned something, you've told them something, and it may not carry over. They've got so many things on their mind. We wanted a way to kind of catch those gaps and figure out if we needed to review anything. Never hurts to offer a little bit more conversation about what's important to the client. We wanted to, the clinicians are always great at that, but doesn't hurt to do a little more and dig a little bit more and have the client think about what's important to them and how the mobility device will impact that. We really wanted to empower the client and caregiver to make the best decisions for themselves. They need to own the decision. It ultimately is their choice. And I feel like if they can own it and get what they feel like is going to work best for them, in my opinion, that's kind of the best case scenario. So we started developing the FIT in 2020, which was COVID. And so we had a little time on our hands, and we were able to do a little research and, look into what are the recommendations when somebody's on the fence? Are there any guidelines for people to go by? Or is there any place for clinicians to look for help making a recommendation? And I really feel like there's a gap in the literature there. And I felt that at that time. So just poured through gobs of peer-reviewed articles. I looked at position pieces by industry leaders, or opinion pieces by industry leaders, and position papers by different, you know, Resna, all the places. And just like I said, felt like there was a gap in the information there. We decided to base the tool on the ICF, the International Classification of Functioning Disability and Health. So y'all are totally familiar with this. This is the schematic of the ICF. The FIT looks at the environmental factor of the wheelchair or the mobility device, and then helps the person consider how the device will impact their body functions and structures, their activities and their participation in relation to their health condition and their personal factors. That's the basis of the whole thing, along with the information we gained from reading all the stuff. We took our categories from the ICF, and there were a lot more than 9 to begin with. These were not the original 9 either. We have changed and changed and changed over time. But originally from the ICF, we got feedback from other clinicians in-house before they had even really done the FIT. We got help from the clinician task force in 2021. And if anybody's in here that's on CTF, thank you for that. We got feedback from our ISS presentation in 2022 about our categories. And then after we had some clinicians at Shepherd do the FIT, we got a lot of feedback from them. So also the whole way through, we're looking at readability to make sure it's at a good grade level for most of our clients. So this is a score sheet from one of our first iterations. So at the top, you write down what device you're considering. You put down how often the person has trialed that equipment, maybe none. It might be the primary thing that they've been using. And then you go through the categories here and score them with a performance qualifier. So that's ICF lingo. A performance qualifier is a score from 0 to 4. 0 being, this isn't a barrier, this is great, not a problem. And 4 being, this barrier is going to make things hard for me with this device. So once each of the categories is scored, you would come down and have a total. The lower total, potentially, the less impact, negative impact that device is going to have, the more positive impact that device is going to have. I do want to be clear from the beginning, we were never trying to say that the lowest score is the answer to this. It's not. This whole thing is like, one of the women I worked with summed it up, and I thought it was perfect. It's like a quantitative approximation of very qualitative data. So I'll just go through one of the categories just to show you kind of how it looked. Oops, there's my stuff. So the saving energy category. This is condensed information from the research that we did, and the clinician would read it to the client, just kind of explaining why saving energy can be really important when you use a wheelchair. Also opening those doors for them to have the conversation. You might learn more things about what's important to the client. After we've kind of had that conversation and gone over the information, the client would score for that device. After using this wheelchair, are you too tired to do things that are important to you? It might be, no, I'm ready, 0, or it might be 4, I'm so tired, I'm not going to do everything that's important. So it's forcing the client to kind of make a decision, make a statement about how this device is impacting them. Another thing that is tough about this kind of thing is, are we scoring the way it's impacting me right now in rehab while I'm still sore, I'm still exhausted, I just had my SP tube inserted, or are we thinking about 6 months from now? And it's a challenge. I mean, I think the important thing is that we are having these conversations regardless. So for this example, if device A was a power wheelchair, frequency of use, it's the primary thing they've used. Let's say they scored a 1, a little tired, but I'll still do stuff, do all the other performance qualifiers, and then you have your total, and then you would go on to device B if they had trialed it. That's basically what it looked like to begin with. Our process map was all over the place. So we knew at this point that we were going to be doing some research. with it. We had an iteration that we thought was pretty good. We were going to deploy it. We were going to ask clinicians to do it for us. We reached out to 21 of the clinicians on the floor. And of those 21, 18 opted in, is what we called it, to administer it to clients that they felt were appropriate. So the process for this was we had to help them figure out which clients were appropriate. We had to figure out who was going to administer it, figure out when it was going to get administered betwixt and between the client's super packed schedule, figure out data entry and who's sharing results, and all this had to happen before the seating clinic. So it was a big process. We plan to, hone it in a lot if it got adopted by the clinicians. So we collected data between April of 2022 and July of 2023. We interviewed all the clinicians. So 18 of the 21 agreed to opt in. Overall, 12 at the end of that 15-month period had actually administered it to at least one patient. And 6 of the opt-ins had not administered it. And we went ahead and interviewed everybody just to get as much information as we could about what worked and what didn't work. Okay, so clinician interview outcomes. Most of the people thought it had clinical value, so that was cool. And most of the things that they stated, we did kind of open-ended questions, and we typed their answers, and then we went back and looked through the answers and found themes. Most of the reasons they thought it had clinical value kind of aligned with why we did it in the first place, so that was a good thing. They found it helpful as a framework, got the patient involved in the process, gives the clinician insight into the patient's roles and priorities, and emotional state is kind of a biggie. So that was good. We did have one clinician who did not find it clinically helpful at all, found that it was just a lot of work and really not a lot of benefit came out of it. The client didn't benefit and the clinician didn't feel like he learned anything from it. So that's good to know. The clinicians felt like the clients who benefited most from doing it were considering multiple devices and or want or need to think about what the device is going to be like at home, because they're still in this little hospital box, and have good insight. That's kind of a biggie. I did a million of these things with people, and sometimes you just have to give it up in the middle because it wasn't working, it wasn't appropriate, person was getting agitated, or not able to follow. It's not for everybody. People with decent insight and good cognition definitely benefit more. But when you do have that client that isn't able to do it themselves, that's a great opportunity to bring in the caregivers that are going to be primarily caring for them and have them think through these things, because they're going to be dealing with it a lot too at that point. Another time that it is beneficial is if what the client wants is not what the therapy team is recommending, and that happens all the time. So benefits for the clients. I liked this one. It helps either validate or challenge the team's recommendations. It's always good to have the feedback on that. Facilitating conversations about realistic expectations about functioning after inpatient therapy. I mean, nobody wants to hear that they're going to need a wheelchair when they leave therapy, when they leave inpatient. But I'm of the mind, I'd much rather them have that conversation before they come to seating clinic than be maybe like, yeah, you're going to need this chair. What color do you want? It's a lot for them to wrap their brains around in seating clinic. So in that vein, it helps them get ready for seating clinic. Just kind of gets their brain in that space. Challenges for the clients, for the clinicians, it can be frustrating because it's not always clear cut. There might be a clear cut device that they feel like is going to work best for them. Team is okay with it, but they can't get it funded. It's tough. And it can be emotionally difficult thinking about how hard things are going to be when they get home. But again, in my opinion, better before seating clinic than just whammy them all at the same time. So benefits for clinicians, they really a lot of them liked the structure versus having casual conversations about these things. It made it easier to document what you had covered. And I liked it. They said that they had increased confidence about the therapy team recommendations. I thought that was cool, and a little less pressure on the primary treatment team to make the right choice, because really it's kind of the client's choice. And then clinician challenges, which none of this was a surprise. It took too much therapy time. Inpatient therapists have so much to cover. I did it for a while. That's part of why I don't do it anymore. It was too long and complicated. They felt like the clinician was impacting the scoring so much that it really didn't even mean anything at the end. They felt like the client's answers weren't accurate. They would kind of give the answer they thought you wanted to make you think that they needed the device that they wanted, if that makes sense. And some of the therapists didn't feel like they were doing it right, which goes back to it being too long and complicated. So the opt-ins who did not administer it, we went to and we kind of asked them, you know, what happened? Why didn't you want to do it? And they basically said, a lot of them said they didn't feel they had appropriate patients. So, I mean, like Ryan works or used to work on the dual team. That's a challenging population because of the cognition. There's all sorts of reasons somebody might not be appropriate. And a lot of people felt too busy to take it on. We had one therapist who was just coming back from maternity leave. There's just life. So we did all these interviews. Meanwhile, Dr. Spiegel was kind of crunching the numbers for us, and he was getting ready to crush my soul with the results.
All right, thanks. So I work at the Shepherd Center part-time, and my job is to help the clinicians satisfy their clinical curiosity, right? And that's a very unique position, right? And so this is Tori's and Mandy's sort of intellectual curiosity. And you know, earlier today we did a little talk about stature, and that was Celeste's clinical curiosity. So I give Shepherd a lot of credit for having this old man sort of help, satisfy this clinical curiosity, because as Mandy said, and as Ryan will demonstrate, they're very busy. They just need somebody like me to just offload stuff. The other thing is, if you have a clinical curiosity, you just have to convince Mandy or Celeste or Tori or Robin or Michelle or Braylon to do something, and then they'll have me do it. So this was a structured data collection thing, right? So you're trying to figure out how this tool works. And it was sort of defined, as Mandy said, for these people on the edge, right? They're sort of, where are they going? They're not a clear cut, power wheelchair user. They're not clear cut manual wheelchair user. They're in this middle. And because they've never had a wheelchair, they're the problem, right? And so the first thing that was done is to start collecting information on people that compared multiple devices. And so as you can see, there's 48 of them. And so that's a pretty healthy set. And it took a while because of life. And then you total up these scores, and we wanted to sort of analyze this data and then look at internal consistency, which is a very common psychometric for an instrument. Internal consistency is basically something simple, right? Does this instrument do the items in this instrument measure the same thing, right? That's sort of what it's after. And so the first thing you do is sort of just take a look at it. And this is a box plot. So fit lower scoring values are better than the undesirable, which is higher values, okay? And so remember, these people compared two devices. And so if you look at a box plot contains a lot of cool data, right? The box is the center 50%. So it goes from the 25 to 75%. So 50% of the values are in there, and then you have a median line. That's the middle line. And it was 0. That means over these people, they compared two devices, and whichever one they chose, right, there was no difference between the less desirable one. So this now gave us an idea of, so the total score was higher for the second choice. That means the first choice, right, had a lower score, right? But here, total score for the first choice, the one they ultimately wanted, was higher. Okay? So it was completely split. So the first thing this does is crush Mandy's soul. Yeah. All right. but it actually was a pretty good thing because it sort of reinforced the purpose of the fit. And the purpose of the fit is not a competition, right? The purpose of the fit is conversation. Uh, so then you do other internal consistency stuff and you find out that, Chromebox alpha is sort of moderate, it's not very good. And that reflects an instrument that's not measuring the same construct. Well, again, it was sort of soul crushing, but to me, it wasn't. It was actually anticipated. If you base an instrument on completely different ICF domains, why would you expect that instrument to be measuring the same thing? It's measuring different domains on definition. I think that's actually not a bad thing. But what it does mean is we don't have internal consistency. Scoring is a waste of time. It's meaningless because it's not measuring the same thing. So that's what came out of this. We saw from this that scoring didn't matter. We saw from this scoring didn't matter. And so we sat down and said, okay, what's next? Right. And that it's okay. A couple other tidbits. So what was next is abandon the scoring. Go back to the core reason for this, which is to have a conversation, sort of force the issue of just, reflection, preparation for seating clinic, yada, yada, yada. Scores don't matter. And then use the feedback from clinicians to solve the problem. Is that operational flow chart, which is a complete train wreck. You just aren't, that's an unsustainable model. A couple other things that were kind of interesting is so power and manual chair compared twice, and 9 times the manual chair was chosen, 9 times power chair was chosen, and a couple times it was unsure. And again, I think that was kind of interesting. And when power assist was involved, it was typically chosen. So if that was on the table, that tended to be a desirable option. So there was kind of some cool things, but it was a transformative evaluation because it really lent itself to how this thing is going to be deployed. You're up.
All right, so a couple of pints of Ben and Jerry's later, we all sat down and we just talked about what have these clinicians told us? What have these numbers told us? And we came up with a new instrument. It's basically the same wording. There's just no numbers involved. And it's worksheets that the client takes home with them after therapy and fills out with their caregivers. So the clinician is no longer impacting the scores at all. It's not taking up therapy time yet. They answer a multiple choice question about how the device impacts that category for them. So it's still kind of standardizing the conversation a little bit. Maybe that's not the right word. I don't know. Spriggle's always correcting me when I use terms incorrectly. Prepping them for coming to seating clinic, empowering them to be involved in the decision. It still gives insight into where the client is, because if what they answer is way off base from what the therapy team thinks and the ATP thinks, then you got another conversation to have. You have some more trialing to do. So I'm gonna share it with you. So I will say I added it as a attachment to the presentation, and the copyright thing didn't show up somehow. So feel free to look at it, whatever. If you're going to give it to your patients, you'll want to get it from the place Ryan's going to show you in a minute. Just please. So with the current process, and you don't have to be able to read this, it's just a lot simpler. The primary team gives them the worksheets a week before seating clinic. The patient completes them with their family. Then they go over them with the treatment team, and then they come to seating clinic kind of knowing what they want, what to expect, what they're asking for. We're actually working on getting it into Epic. The plan is that it will just pop into their MyChart 1 week before their seating clinic appointment, and they'll get a notification to do it if they want to do it and if they feel like it's appropriate. It's not for everybody. And then if they do it in Epic, then it will automatically be available for the seating clinician to look at whenever they do so that's the plan. This is a slow process, y'all. Shepherd is not quick. You can ask Spriegel with how that goes. So this is most of the first page of the fit. It's just kind of explaining what the worksheets are, what it's going to be talking about. It asks them to indicate what device they're filling out the answers for. So you do one packet for each device you're thinking about. It might be one device. And then it just goes through the categories. So just like before, it's got the blurb at the top of the information for them to consider why this category is important to think about. It still requires that the client consider everything and choose an option. Like there's no more wishy-washy, they have to say, this is how this impacts me. This is how I think this is going to impact me. There's still the 5 options to choose from, just like the ICF. And you can still tell if what they're saying is way off base from what you're seeing. Energy, very similar to before. It just kind of facilitates more conversations. Anywhere from I'm ready to go do it to I'm extremely tired and I won't use the chair, essentially. Stress on your joints for us, this one is mostly, and we put a bunch of joints up there just for them to kind of think through what is this impacting. But for us, it's mostly shoulders. It's a really good opportunity to talk to people about the long-term impact of repetitive use for shoulders that may not be strong enough to handle it yet. One of the things I always encourage and I find really helpful is when I actually borrow the person's cell phone and videotape their shoulder blades while they're pushing across the gym or across their room if they don't feel comfortable with their shirt off in the gym. And they can actually see what their shoulder blades are doing and we can talk through, these are some long-term things. Maybe you need to hold off on that a little bit or anyway, that's the joints one. Posture, just it gives us an opportunity to talk about the tendencies we see. Everybody has tendencies. Nobody's sitting great in these chairs, although they're all still flexible when it's typically a new injury. We can talk about how important repositioning is and what the long-term impact could be if they're not able to reposition themselves, if they're not able to do those weight shifts, if they are not properly supported, what's going to happen to their posture, and what are some ways to mitigate it if that's still the device that they're choosing or leaning toward. Independence, this one is all about how long they can be away from a caregiver. And if you told me, hey, you can't do a weight shift in this chair by yourself, you're going to need your mom there every 30 minutes, that would give me pause. I would not be happy with that. And I feel like it's a pretty meaningful one for everybody to look at. It just kind of talks them through what do you need help with when you're using this device. And then at the bottom, how long can you be by yourself? How long can you be without a caregiver and be safe? Moving around using the device. We've got the blurb and then just some different things that maybe people haven't thought about because they're in the hospital. Everything's accessible. Everything's flat. I mean, our floors are not flat. They'll tell you that in a heartbeat, but not a lot of ramps, not a tiny elevator anywhere. Doorways are all huge. So just kind of give you some ideas. I think one thing that my people with tetraplegia don't think about a lot initially is stopping when they're going down that ramp or stopping when they're going down Peachtree Road. I don't know if y'all have been to Atlanta, but it's a huge hill. So can you move around using this device? Yep, no problem. Or no, I can't do anything without help with this chair. And I guess my thing is, if they realize they are going to be dependent in this chair and they're okay with that, I'm okay with that. It's their funding, it's their choice, it's their life, in my opinion. Not everybody shares it. Moving around using transportation, I'm sure everybody's heard people come in, oh, I want a manual chair because it's going to be easier to get around my community. But have you tried a transfer in the car with your mom yet? Because it's not easy. And, so it just kind of goes through what kind of transportation might be available to them, and how hard it might be. Have they tried the transfers? And how hard is it going to be to get around in the community? This is a great opportunity to get case management involved and or rec therapy in our facility. Again, we're spoiled rotten. We've got all these people that can help. But to look into their communities to see what kind of resources they actually have available to them. Although I'm shocked, Spriggle, how many people refuse to take MARTA? Yes. Some people absolutely not. I am not taking MARTA. No way, no how. It's fascinating. This one is huge because if somebody doesn't feel good about themselves when they're using the device, they're not going to use it. I don't want to prescribe something because it's most appropriate and then they're laying in bed. So this is a great opportunity to get, your counselors involved, or if it's totally inappropriate what they're kind of wanting, or this is an opportunity to see where the gaps are in their understanding. It's also an opportunity to figure out which professionals you need to bring in to help this person make a good choice. And then of course, funding. What are you planning to use? Have you talked about the pros and cons, like the repairs and that sort of thing? And can you get it paid for? And it's always a good opportunity to bring up who is your supplier, because everybody comes in, I don't know who my supplier is. Really? You just, anyway, good conversation pieces. So that is the last one. And then Ryan's gonna talk to you about some of the folks he worked with.
Hello, I'm Ryan. I'm a physical therapist at Shepherd. Primarily have worked inpatient for the past several years, so I wanted to kind of just like give you a glimpse of what that is if you're either not from here or not a clinician. But so in my experience at Shepherd, I'm what's called like a primary physical therapist, where I have the same 5 patients that I'll oversee the whole course of their rehab. I work with them for an hour and a half a day, and of course I'm progressing their mobility, but as it relates to their wheelchair, I'm the person who's setting them up in the first like trial wheelchair that we have in the hospital. We have a wide stock of things we can use, power and manual. If someone's like starting in a power, but eventually gonna try a manual, I'm timing that. I'm considering all the factors that go into that. We get to do a lot of unique things where we take people out in the community. We can train family members on certain things so that they can go out in the community with our chairs, so that the patients aren't just getting experience only within the gym or within the hospital walls, which I think is helpful. And of course, I found value to this tool. I think it's really challenging when you have someone that's really in the gray zone between 2 different chairs, and you want to think towards the future for them, but maybe how quickly they're progressing, you can't control every aspect of them. And there's obviously big implications if you get them the wrong thing. So the first person I'll talk about today had C6 Asia B SCI. I'm going to sort of follow the ICF to kind of paint a little bit of a picture of him. So first, he was 41 years old, very motivated. He was an athlete. He used to travel all the time. He did have good financial resources, which made an impact on our decision-making to an extent, and did have supportive family, although certainly a factor was it was tough for them to accept kind of his condition where he was, even though we had so much to work on mobility-wise with that C6-7 motor complete level of injury. I was still being daily asked questions about working on legs and things like that. I think it's pretty commonplace in our world. So some other things about him: he did have he had shoulder pain and previous injury from his sports background. He did have innervated triceps, but they were a bit asymmetrical, and that took some time to kind of build up over the course of his day. It wasn't fully intact. And he was fairly tall and lean with long arms, which from my point of view was a pretty good body type for this level of injury. So in my brain, he was someone who was definitely could be manual chair appropriate or manual with power assist, even though that's not where we started. So as we're progressing, he couldn't transfer on his own. We're working on that. That takes a long time for this kind of person to work towards. Started in a power, had lots of issues with blood pressure regulation, with transition out of bed in the mornings. I'd say around the time of his manual e-chair or his wheelchair eval, he could push a manual chair, a rigid frame manual chair on level surfaces, but needed help with hills distances, extended outdoor terrain, things like that. And did have experience doing that in and outside of the gym. Participation wise, he was a parent, again, very active, outdoor kind of thing, very social kind of person. So in terms of the options we're considering, it was basically, do we go custom power chair or custom manual chair likely with power assist, so he could certainly move around, not being totally sure of what could be covered. Even though he had support, we kind of knew that he wouldn't have 24/7 support, and he needed aspects for a number of extra things such as ICs and things of that nature. Next slide is kind of highlights some pros and cons of either one. So pros of the power chair: less energy expenditure. He could consistently and efficiently mobilize in and around wherever. Cons, he wasn't really too keen initially on getting it some means to transport that chair. And he didn't feel as good as himself, to use the language of the fit, in the power chair compared to the manual, even though it was easier to get around. Manual chair, he did feel better about self, easier to transport. Cons were he's still building his ability to use it functionally and efficiently, needed more help with certain things from it. So we did the fit with him, and I guess maybe another factor to consider is like what I would have probably scripted for him without just looking at his body. I probably would have thought probably manual and power assist wheels initially, just thinking, you know, he's going to continue to get better. He's strong. He's fairly young. That probably would have been my gut reaction. But at the end of the day, he ended up going with a custom power chair. He did have the means to pay for a custom ultra lightweight chair, which is very nice. That wouldn't be the case for everyone, of course. But he was definitely happy with the decision. I had a follow-up conversation after he had several months of kind of using both. Some things he liked about having the power chairs, he didn't have a vehicle to get around, but he lived in a flat area around a beach. He kind of used that as his vehicle to an extent, for at least at this earlier stage when they're still acclimating. He liked that he could use it to work out at the gym and mess around with the power seat functions to make that more efficient and be stable. He said he sort of had been in and out of the hospital for various reasons at the beginning, and just sitting up in the manual chair was a challenge. And on those days, either like when physically he was down or mentally, like he wasn't feeling it, he still could get out of bed and do what he wanted or needed to. And the manual chair, he did continue to say he kind of felt better about himself in that chair. What is the time? Do I have time? Oh, we got time. Good. And then I don't know, some other factors he said. I mean, he appreciated going through the fit for sure. It helped him like have that intentional focused decision making leading up to that decision. And I put off this decision as long as I could. I mean, in our hospital, we're sort of expected to have the scripts in by about 2 weeks before they leave, but I don't know, at the same time, you want to get their scripts in early so they get the chair sooner. Anyway, another challenge. But he said he appreciated, after he left, having looked at more resources of people who had gone through this sort of pros and cons of each. Like I think he looked at social media and things like that. He admitted during inpatient, it's not that he had no access to that kind of peer support at all, but he wasn't ready for that mentally. So another challenge in this decision-making process is that not everyone's kind of ready for this. But I don't know. I think by doing the fit and really not being afraid to have some of these conversations they might not be open to, I still think it's your best interest to attempt that. And there's him kind of using both of the devices. So the next person I'll discuss, a little bit different situation. Still, he's motor incomplete, tetraplegia, had one hand with functional grasp, the other only had tenodesis. Leg movement was not very strong, and he was a bit older. So to highlight some more things about him, using the same format, 67 years old. He was partially retired, but works as a collegiate sports coach. Travels a lot, both for that, and he has family that's out of state. Some extra things about him. We found out while he is inpatient, he had a chronic ACL tear, so we had some limitations with any of the kind of standing stuff that we were attempting at the beginning. Ended up finding out that he had HO and bilateral hips and had some hip range of motion limitations, and his spasticity was really not controlled, I think largely in part to that. He did have some cognitive impairment, really kind of higher level reasoning and retaining of information kind of things, which limited to somewhat my initial discussions about thinking about the wheelchairs. In terms of his mobility at the time that we were thinking about the chair, he was progressing pretty well with like level transfers and unlevel things. He was hoping to work towards standing, or we did some of that, but it was so limited by like we kind of had to prioritize transfers and addressing the spasms and range and stuff, and considering the wheelchair aspect. So, and his knee was inflamed, so we it was just a challenge and not really clear how much he would progress from a standing walking standpoint, but not looking to be someone who will be a no limitations functional ambulator, that's for sure. He primarily was using a manual chair indoors, but certainly for anything outdoors in the community, he had to rely on power mobility, or was using our equipment when we went on outings to the community and things like that. As I said, he's a sports coach that travels all the time. And he's a regular exerciser, like a very active person that worked multiple jobs, that sort of person. So we were considering power versus manual chair. In my brain, I was definitely thinking this person is definitely gonna need power mobility to some extent. I mean, he travels all the time. Like he can't get around efficiently. He's going to and from these different places where who knows what terrain he'll have to manage. Even though he had someone that was willing to assist, like to me, he just wasn't quite coming to reality with probably what his limitations would be. So I felt good that having this conversation to help him make decisions about that. Oh, and he did not really at all want to have an adapted vehicle, and lived in a really hilly area too. So the power seemed sort of like no brainer to me. Kind of already talked about pros and cons of this, I think, to the most extent, but yeah, I think we sort of already covered most of this, but to me on paper, there were more advantages to power than manual. That being said, we did the fit, and of course, unsurprisingly, he chose a custom ultra lightweight manual chair. And he did continue to need help for certain things as he adapted to things. He did participate in the season of his sports team was like right after he discharged. He went right into that with this. And following up, he's still happy with his decision. I think despite all of the maybe things that are maybe in the longer term going to limit him, and he eventually might choose to get a power mobility device, like where he is now, both physically and with considering all the factors for him, that was the right choice. And yeah, he literally said, I would keep the chair if I had to do it again. Granted, it's only been a couple months. Like, will he think the same thing in a year or two? I'm not sure, but I feel good hearing that despite the challenges. So to kind of work towards concluding, for who do we think the fit is most beneficial? Well, I think for anyone, even if they're not someone who's in that gray zone between two chairs, I think it helps just kind of structure my format of what are all the things I should go over with a person as they're considering a chair or just being a wheelchair user in maybe the longer term. It's a good way to have more discussion before I just send my client down to Mandy for their seating clinic, where they're going to talk about so much in a really short period of time. It helps, I think, the individual to consider more post-hospital, even though we're attempting to expose them to those thoughts and ideas before going home. Hopefully they can think a little bit more about that. If I go home as I am today, how would that go with either device? And yeah, and I think I feel a little better if I do think that person still may choose the device that I think is going to come. We're going to come back with negative complaints about it. I don't know. To me, it's a little bit of a due diligence thing. Who is it least helpful from? Someone who hasn't really had a lot of exposure to one device. So if I don't know, if someone's been in a manual chair once and then they have a power chair, are they really going to have the same experience as someone who's had a lot more experience? The cognitive impairments, of course, can make this more difficult. I'm in agreement with involving the caregiver, but one other thing I have done is most of my patients with cognitive impairment are working with a speech language pathologist, and I have collaborated with that person to have them within their session do the fit with them. That way they're actually doing it. It's like, are they really going to do it if I send the paper home with them? I mean, even if they don't have cognitive impairment, that's like they're tired after therapy, their families visiting them, they have bowel programs to do at night. It's just like, how are they going to fit that in, even though there is time per se? Anyways, I still think that doing it with them, even if it's not totally unbiased, can help them to think more than they otherwise would, regardless of how much they grasp. And yeah, if someone's really either cognitively rigid or firm and definitely what they get, is it really worth their time? Probably less so. Anyways, if you want to access the fit, if you go to this website, it's kind of a website that has resources of all sorts of types. So feel free to look through whatever might be there. If you scroll down to the bottom of the main page, you'll find view all resources. Click that. Sorry, I was going to pull this up and show you, but it wasn't working at the beginning. A functional impact tool for mobility devices, that's on there, and you can access it if you'd like. And that concludes our presentation. Thanks for listening.